Thank you very much for joining us on our latest media briefing on important health issues in the news. My name is Dr. Rose Zacharias. I'm the president of the Ontario Medical Association, which represents more than 43,000 physicians in Ontario. October is Breast Cancer Awareness Month, so we have assembled an expert panel really to talk about the #1 cancer affecting Canadian women. 1 in 8 Canadian women can expect to be diagnosed with breast cancer in their lifetime. Screening mammograms are the best method for detecting breast cancer early and can usually find lumps before women or their doctors can feel them. Finding cancer early means it's less likely that the cancer has spread, and of course that treatment can be started sooner, very important. A new analysis by the Ontario Medical Association found there were 422,000 fewer mammograms conducted during the pandemic than would have been conducted based on historical records. And although screenings have returned to forecasted levels, many women still haven't had a mammogram since before March 2020. Experts worry that this means there are undiagnosed cases of breast cancer yet to show up. And some women are being diagnosed with bigger lumps and more advanced stage cancer, meaning that treatment is much more complicated. Breast cancer patients are waiting longer for treatment than they were before the pandemic, and this includes their surgeries. Longer wait times can have negative effects, as you can imagine, physically, but mentally, emotionally, psychologically. This highlights the urgent need to clear the backlog and then fix the wait times. One of the pillars of the Prescription for Ontario, our 5-point plan for better healthcare. So thank you so much for joining us on an incredibly crucial topic this month and every month. I would like to introduce our panel of experts who are going to discuss these issues in more detail. Dr. Jean Seely is a radiologist who is a professor in the Department of Radiology at the University of Ottawa, head of breast imaging section at the Ottawa Hospital, and is currently president of the Canadian Society of Breast Imaging. Welcome, Dr. Seely. Dr. Erin Cordeiro is a breast surgical oncologist at the Ottawa Hospital and medical director of its Breast Health Center. And lastly, Dr. Timothy Hanna is a radiation oncologist and associate professor at Queen's University Cancer Research Institute's Division of Cancer Care and Epidemiology. So welcome to our expert panelists. Thank you so much for being in the Zoom room today. And let's start with you, Dr. Seely. Please tell us about the impact of missed mammograms and what are you now seeing in your hospital, and in your opinion, can you speak about early detection and how important that is? Thank you.
Thank you very much, Dr. Zacharias, for the ability and opportunity to speak. So we have a significant backlog in Ottawa, very similar to across the province. And we stopped screening for a 3-month period just when the pandemic started. And what we have seen with this delay and some women not returning for screening as quickly as they should is that in the pandemic, we are now seeing more women presenting because of symptoms of breast cancer instead of when they're found by screening. During the pandemic or before the pandemic, we know that about 50% of all breast cancers were detected without symptoms found with screening, which means that they were more likely to be early stage, defined as stage 0 or stage 1, and would require less intensive breast surgery and chemotherapy. During the pandemic, we have seen a dramatic difference in the number of screen-detected breast cancers. Our hospital diagnoses and treats about 1,200 women with breast cancer every year. And now during the pandemic, only a third of those, 29%, are screen detected. And this means that over 70% are diagnosed because they have a symptom of breast cancer, typically because they present with a lump that either the woman found themselves or that their physicians found in their breasts. This means that the cancers are more advanced at the diagnosis stage, and that would be defined as stage 2 or 3, or even, and we're seeing this, de novo stage 4, which means that they've already spread to other parts of their body, which is not curable at that time. They require more intensive chemotherapy and more extensive breast surgery, like a mastectomy or a full axillary lymph node dissection. And when we have breast cancer diagnosed at an early stage 0 or 1, the 5-year survival is 98%. When it's diagnosed at stage 2, it decreases to 80 to 88%. And when it's diagnosed at stage 3, it drops further to 77%. When it's diagnosed at stage 4 at diagnosis, it has a survival rate between 20 and 39%. Very, very difficult at 5 years. Many women die of this disease. So the delays in screening are leading to poor outcomes for our patients, and they're affecting their long-term survival. I will highlight that this supports our study where we evaluated 55,000 Canadian women diagnosed with breast cancer in collaboration with Statistics Canada. And we looked at women in their 40s and 50s, and we found that when women were not screened in provinces and territories that did not include women in their 40s, there was a significant increased number of stage 2 and 3 and 4 in women in their 40s and in women in their 50s. So not screening translates to this worse outcome with a more advanced stage. And it also aligns with a very large study, the Pan-Canadian trial that was published in 2014, looking at 2.8 million women who were screened in Canada, and they were associated with a 40 to 44% increased survival when they were screened as compared to women who were not screened. So this really is having an impact on women diagnosed with breast cancer, and the impact of COVID is really what we're seeing in Ontario and in Ottawa particularly.
Thank you very much, Dr. Seeley. Appreciate that extremely compelling data, and I appreciate you sharing that. It will spur our conversation on. At this point, we will move on to Dr. Erin Cordeiro. Thank you so much for being here. And are you able, from your experience, to just speak about how the pandemic impacted wait times for breast cancer treatment? Thank you, Dr. Cordeiro.
Thank you very much. Thank you, Dr. Zacharias, and thank you for the opportunity to speak today. As we all know, the pandemic has really caused increased stress and strain across all aspects of the healthcare system. And specifically with regards to breast surgical oncology, we're really noticing a significant decrease in the access that we have to OR resources and specifically to operating room time. Mostly this is due to a shortage of healthcare personnel and human resource constraints. Similarly to how restaurants are having difficulties with servers, we are also having difficulties with healthcare resources and human resources within the hospital system. So I really want to try to illustrate this point by describing the journey of a typical fictitious patient and what she would currently be going through in our healthcare system right now. So I'll tell you the story about Nancy. Nancy is a 50-year-old woman who notices a lump in her breast in early June of this year. She phones her family doctor and is able to get an appointment in 2 weeks' time. Her family doctor sees her towards the end of June and orders a mammogram and ultrasound. Currently, those tests would take about 6 weeks for the patient to have done, so she has those done in mid-August. She then requires a biopsy, which again takes about another 3 to 4 weeks to be organized, so that happens in mid-September. The biopsy results take about another week to come back, and unfortunately, they have shown that she has a breast cancer. Her primary care physician then refers Nancy to a breast surgeon who sees her within 2 weeks of having the referral, so she sees me in clinic today on October 12th. The surgeon tells Nancy that because of her dense breast tissue, she recommends having a breast MRI, which then takes another 2 weeks to organize, happens the end of October. After those, the surgeon and Nancy are able to come up with a plan of care, undergoing a mastectomy, sentinel lymph node biopsy, and her surgery is scheduled at the end of November in about 4 to 6 weeks' time. So in summary, from the time when Nancy first noticed this lump in her breast in June until the time of having her definitive cancer surgery, the end of November, it's about a 6-month time period that has elapsed. This time waiting for testing and surgery is obviously incredibly stressful for patients and their families. And compounding this issue is also the backlog that we have of postponed surgeries from the past 2.5 years. Because of our current resource limitations, we're actively prioritizing patients with cancer to try to get them done as soon as possible. And so our prophylactic patients, our patients who are awaiting delayed reconstruction, are facing wait times of over a year to have their surgery at this point in time. In addition to the stress and anxiety that the patients and family experience in all this situation, healthcare professionals also experience a large amount of stress and anxiety over these wait times, and it's very distressing to us. These wait times are really causing symptoms of burnout amongst healthcare professionals who have been working diligently to provide support to these patients over the past 2.5 years in a system that is struggling. I thank you very much for the time to talk today, and I'm happy to answer any questions.
Thank you so much, Dr. Cordeiro, also for outlining a patient's journey, but also highlighting the burden on the healthcare provider and indeed how I mean the ripple effect of the difficulty we're in affects so many of us. Thank you. At this point, Dr. Tim Hanna, thank you so much for joining us. Are you able to now speak to how delayed diagnoses and treatment impact outcomes? And are we seeing similar trends in other kinds of cancers as well? Dr. Hanna.
Thanks, Dr. Zacharias. What you've just heard from Dr. Zacharias, Dr. Seeley, and Dr. Cordeiro is so important because with breast cancer and with other cancers, time is of the essence. With breast cancer, early detection improves survival. Shorter waits for treatment are associated with better survival for breast surgery and for chemotherapy needed by some women who have breast cancer. For example, in our research published in the British Medical Journal, we found that a 4-week delay of breast cancer surgery was associated with 8% worse mortality. This means that for 1,000 women waiting for breast cancer surgery, there will be 10 deaths due to the extra wait. Excuse me. The longer wait for treatment, the worse the impact on survival. We've seen the same pattern for other cancers, including cancers of the colon, rectum, cervix, head and neck, and bladder. This is important as the same trends in waiting times and backlogs are affecting other cancers. For example, we found that in Ontario, in the first 6 months of the pandemic, a backlog of over 45,000 skin biopsies developed. These biopsies are needed to diagnose skin cancers such as melanoma. Across Ontario, we saw a large drop in cancer screening tests affecting all types of screening in the first year of the pandemic. This represented a 42% drop in screenings, representing over 1 million less screening tests in Ontario, affecting diagnosis of breast cancer, colon cancer, lung cancer, and cervical cancer. So this is certainly a system-wide issue whose consequences are now emerging and certainly requires action. And I'll look forward to the conversation that follows.
Thank you, Dr. Hanna, very much. Indeed, we've highlighted a lot of numbers and the system issues, but I think what you are starting to understand is under every number is a person and their story and their family and their experience. And as physicians, we came into our profession to care for people, and yet our system has huge fractures now after the pandemic, especially. And so it is so important to highlight this issue today. So we are ready to take your questions. I know that many of you have put your questions in the chat. Emily English here at the OMA is going to field questions and direct them to each of our panelists and myself as well. You can also email, just a quick reminder, media@oma.org with additional requests for interviews following our Q&A, and we will have a recording of the session available. So I'm going to turn it over to Emily and we'll get to the questions.
Thank you very much, Dr. Zacharias, and thank you to all our panelists for participating today. The first question is for Dr. Seeley. Can you tell us more about what wait times are like now for mammograms? Does Ontario have the infrastructure it needs to stay on top of the demand?
So that's an excellent question. And we have a number of issues in terms of tracking those wait times. We only track those wait times for the Ontario Breast Screening Program. And they have published wait time for waiting for screening depending on the region. So every region is different. The wait times are high. In our region, for example, it's 3 months for a screening mammogram. But again, it depends on where in the region you are. Some places have a wait time of longer than others. The capacity issues are tremendous. We do not have enough trained technologists. Those are the women who typically do the mammograms in Ontario to perform all of these screening mammograms. There's been a tremendous retirement, an aging group of technologists, and insufficient training for these technologists. So we have to train more, and we also need better trained radiologists to be able to do this work. So we need that infrastructure in place to help with that capacity issue.
Thank you very much. And the next question is for Dr. Zacharias. Can you explain how the OMA got to the number of 400,000 missed mammograms?
Sure, yes. So it's important to understand that this number from OHIP, pulled from OHIP billing data, is not a backlog number. You just need to think about what amount of mammograms would have been done had we not been dealing with the crisis of COVID. Obviously, we were dealing with the pandemic, nobody's fault. That was first priority. But had we not been dealing with the pandemic, 400,000 more mammograms would have been done. So those did not get done. And so now when women are catching up on their missed mammograms, their cancers are more advanced. The treatment will be more complex and involved and invasive potentially to treat their cancers. And so it's really a number based on our historical trend, the amount of mammograms that were missed.
Thank you very much. And the next question is for Dr. Cordeiro. With the bottleneck of surgeries, how are different kinds of surgeries being prioritized? How long are the waits for things like breast reconstruction surgeries?
Thank you for your question. I mean, we do have to think within the context of the entire healthcare system, and certainly oncology surgeries is a small component of the entire backlog of surgeries that any one hospital has. Based on directives from the Ministry of Health, we are doing our best to prioritize any patient that is waiting over target. So for every disease process, including benign and malignant, there are target wait times that exist. And so we are doing our best to prioritize any patient that is over target, either both benign or malignant diseases. And then, so as I mentioned, basically over the past 2.5 years, we've not been able to do very many prophylactic or delayed reconstruction cases at all, because we have been struggling so much to even get our cancer cases done. So current wait times for prophylactic delayed reconstruction across Ontario are in the 1 to 2 year range.
Thank you very much. And the next question is for Dr. Hanna. Dr. Hanna, is Ontario seeing similar trends across other kinds of cancer in terms of later diagnoses due to misscreenings?
Right. So unfortunately, the detailed provincial data is not out to answer that yet. We're still waiting for detailed stage information on the first year of the pandemic, which will give us a better sense. But certainly there are signals that we would expect similar trends across other cancers. I treat skin cancer as a radiation oncologist, and certainly in my practice, I saw a wave of more advanced cancers that I think were linked to delays in diagnosis.
And thank you very much for that answer. We have a question from Len Gillis at Sudbury.com. I'm going to direct it to you first, Dr. Seeley, and perhaps Dr. Hanna, you might like to weigh in on this one as well. In terms of screening, should there be some sort of a focus blitz on screening throughout Ontario to get more women screened? And should we be petitioning hospitals or the health ministry to put aside other MRIs and other procedures so hospitals can focus on urgency of breast cancer screening for a brief and focused period?
I think that's an excellent suggestion. I welcome those kind of ideas because we're struggling with backlogs in many different areas, but breast cancer is the #1 breast cancer that affects women in Canada. And it's the #1 cause of cancer death in women under the age of 55 in Canada. So it's a tremendous impact on our whole healthcare system. The resources are being shared, so we'll have technologists pulled away to support other areas of the hospital, and that then decreases the backlog. We have the same with MRI. So this needs a collaborative effort with the hospitals to understand how to address this, but I welcome those kind of ideas. I think they're the way we can help to use our resources effectively.
Thank you very much. And Dr. Hanna, did you have anything to add?
Well, I agree with Dr. Seeley. I mean, this needs to be seriously considered, and it's a collaborative process, as we don't want to take resources away from something else that'll even affect outcomes even worse. But certainly, given the impact on mortality for delays in diagnosis of breast cancer and delays in treatment, I think it needs to be carefully considered.
And Dr. Seeley, another question for you, if you could weigh in on this. It's from Mike Crawley from CBC News. Can you translate what 420,000 missed mammograms means in terms of actual cases of breast cancer that would have not been detected?
Oh, great question. So we know from the screening programs that in Ontario, for example, our average cancer detection rate is between 5 and 6 per 1,000 women screened. There are other women who are not screen detected. Mammograms are not perfect, and we have an interval cancer rate of about 1 per 1,000. What that means being a cancer diagnosed after a normal screen. So you can do the math. If we estimate about 7 per 1,000 cancers not diagnosed in 400,000. I don't have my calculator, but that's the approximate number of cancers that have not been diagnosed with screening. What that means is that they are going to be diagnosed with a symptom. And this is what we're seeing with women presenting with a symptom of breast cancer. And I did see a question, maybe I could answer it in this context. A symptom of breast cancer is something that the woman presents with as a sign of breast cancer. She might feel a lump in her breast, but there are other symptoms of breast cancer. There might be inversion of the skin or the nipple, dimpling of the skin, thickening of the skin, a feeling of an axillary mass, or a bloody nipple discharge. Those are all symptoms of breast cancer that indicate that the cancer is typically at a more advanced stage. Thanks.
And thank you very much for that answer. There's a follow-up question from Mike Crawley with CBC News. We're talking about Ontario, but is it possible to project the number of missed mammograms to a national scale? Wondering, Dr. Seeley, if you have any statistics or data on that.
That's a great question. Ontario has the largest population. We know that these statistics are emulated across Canada, but I don't have the actual figures. Again, this is not tracked nationally. It's all dependent on each provincial healthcare system. But you could estimate that we could probably multiply this by at least 5 times to meet that kind of population expectation for the rest of Canada. I don't know if Dr. Hanna has those figures from a public health perspective. Tim, what do you think?
No, unfortunately not. Every province has their own information. And I think the other thing to remember is that decisions made about reducing or stopping screening varied across provinces and would also have been affected on the degree that they were impacted by the pandemic at different times.
Thank you very much. And we have another question about surgery. So I'll direct this one to Dr. Cordeiro. What resources are lacking in operating rooms and causing surgery delays?
Thank you for the question. It really, the vast majority is human resources across the board. So, to run an operating room takes at least 6 to 12 people. There's not only the surgeon, but obviously the anesthesiologist. And then there's the nurses who are in the room, both the scrub nurses as well as the circulating nurses. And then there's also all of the ancillary staff that are required, the preoperative nurses, the postoperative recovery care nurses, for patients who are being admitted, having access to beds in the hospital that those patients can then go to. So it is such a complex medical system that we live in. And so experiencing shortage in any one of those aspects just snowballs into problems for the entire system. So we have seen significant decreased human resource availability within all of those sectors. And I know here at our hospital, we've seen about a 20 to 30% loss of perioperative staff throughout the course of the pandemic.
Thank you very much for that answer. We have a question from Mirna Dukic at Radio Canada, and Dr. Seeley, she's asking if you are able to, if you could answer in French, if you could. Tell us the consequences of the missed mammograms. Do we have data on the number of women being diagnosed in stages 2, 3, and 4 compared to prior to the pandemic?
Merci beaucoup pour la question. La question, si je comprends, est-ce qu'on a les statistiques des stades à diagnostic du cancer du sein depuis la pandémie? Et c'est une question excellente. Nous sommes en train d'étudier ces taux à l'hôpital d'Ottawa, mais c'est une étude en progrès. Alors, je n'ai pas encore les détails, mais on peut corréler avec les autres études. Parce qu'on sait que si on attend pour un cancer qui est palpable ou symptomatique, on sait que les stades sont plus avancés, stade 2 et stade 3, et c'est ce on va vérifier avec notre étude qui va être finie à la fin de cette année. Alors, je n'ai pas les données particulièrement pour Ottawa, et ce n'est pas encore évident en Ontario, mais ça va être certainement sûr que les taux vont corréler. Merci beaucoup pour la question.
Thank you. And a follow-up question from Mirna Dukic at Radio Canada. This one, if any of the panelists would like to weigh in, but we'll start with you, Dr. Seeley, if you could answer in French for Radio Canada. What concrete action should the Ministry of Health take to address this issue?
Alors, il faut vraiment porter attention à ces délais dans le diagnostic de cancer. Il nous faut les ressources augmenter les ressources afin de faire le dépistage mammographique, donner plus de technologues, entraîner plus de technologues, porter attention à toutes les ressources demandées pour la chirurgie et le traitement. Maintenant, on a de plus en plus moins de personnel à faire ces études et il nous faut plus d'attention et de ressources pour le faire. I'll turn it over to my colleagues for their comments as well.
Yes, and the question was, what steps can the Ministry of Health take to address this issue? If there's any other panelists who'd like to weigh in.
I'm happy to weigh in, Emily, although I don't speak French and will need to give my answer in English. I mean, our prescription for Ontario has been what has outlined our recommendations to the Ministry of Health all along. It's our most extensive consultation. It is not just the voice of Ontario's doctors, but it is the voice of all external healthcare stakeholders and our patient population as well, and what needs to be prioritized. I'll highlight just 3 of them here. We have to address the doctor shortages. It was mentioned by Dr. Cordeiro, a functioning OR requires anesthetists, anesthesiologists, and we don't have enough in our system. We don't have enough family doctors. More than 1 million people in Ontario don't have a family doctor. So the preventative care and the screening is just not happening because people don't have that relationship with a family doctor that takes charge and works with them to prevent medical illnesses that could be on their horizon. And so we need to address the doctor shortages by looking at barriers to licensing foreign trained doctors and bringing them into our system. That is something that we are working even now with the College of Physicians and Surgeons of Ontario, and we welcome the announcement from government to expedite exactly that. It is one immediate solution. We also welcome the news of increased medical student spots and trainee spots in residency programs, but that's long-term. It takes years, 3, 5, 8, 10 years sometimes to train a physician. And so we find ourselves in this situation now. We need some immediate solutions. We need some long-term ones. And we are committed to working with government inside the Ministry of Health to see our solutions implemented.
And Dr. Cordeiro, another question for you. You mentioned burnout among physicians. Can you tell us more about how hospital staff are dealing with caseloads now that are more complex?
There's no simple answer to that. It's a challenging problem. I think, you know, we all got into this to help patients and to do what we can to save patients, and it just breaks our heart on a daily basis to have to see patients who are waiting, who are suffering, who are struggling. And so I really have to give a huge kudos to all of our perioperative staff who are trying their best to go above and beyond every day to make things happen. One of the biggest implementations has been making the OR days last longer. So, pre-pandemic, most of the ORs ended at 3:30. We've now been able to extend a lot of our OR time until 6 o'clock. So adding that little bit of extra OR time on the end of every day. And so it's wonderful that healthcare professionals are willing to do that. But again, it does add to burnout and stress when your working hours are now becoming longer and longer. So we have lots of access to wellness resources, but as time goes on, it becomes more and more of an issue.
And Dr. Zacharias, can you talk more about how the pandemic has impacted physician burnout overall and how it can be managed?
Absolutely. We undertook a study in mid-2021 and asked our physicians in Ontario, and nearly 3/4 of physicians at that time, nearly 75% of doctors said they were operating at levels of burnout. And so we know this has a huge impact. We asked why. We know that the amount of documentation that is required of physicians is completely disproportionate to the amount of patient care that they provide. For every 1 hour a doctor spends with a patient, they are documenting for about 2 hours. So it takes doctors away from being in conversation and in relationship with their patients when they're at a glitchy computer screen. Our technology hasn't kept up either. Our computers don't speak to each other. There are so many forms to be filled out by physicians in order to get patients through the system. And so these things need to be streamlined. We're committed to working inside the system with our external stakeholders to decrease that administrative burden on doctors, but we know it's the #1 reason why doctors are experiencing burnout. Really working inside a system, doctors are high capacity, resilient individuals that work very hard, but they're working inside a system that has major cracks that have now become chasms as a result of the pandemic and the strain of dealing with COVID. And so we are committed to working with all stakeholders inside the system to reduce burnout.
And the next question I'll direct towards Dr. Seeley. Is there anything more women and men can do in addition to checking their breasts and underarms regularly for lumps?
So the problem with doing that kind of clinical, like breast exam, is it hasn't been shown to reduce the mortality or the morbidity of breast cancer. We recommend being breast aware, breast self-aware. So that means being aware of any changes in the breast or in the armpit. But the best way to be proactive and be healthy is to detect a breast cancer before it has a symptom of breast cancer, before it's a lump. And that's why we recommend screening mammograms starting at age 40 for all women, regardless of their risk factors, because that's the way we reduce the breast cancer mortality and the significant treatment impact from an advanced stage diagnosis. So I hope that clarifies it. It's a area that we could talk about in more detail, but I think this is the great opportunity to share this multidisciplinary approach and to have the OMA really advocate for a better system here, because we're really identifying these system issues that are delaying the diagnosis and affecting the health of our women in Ontario.
Thanks very much for that answer. The next question is for Dr. Hanna. You outlined statistics about how wait times affect survival rates. What kind of treatments are most commonly delayed?
So the general experience, and this is across jurisdictions in Canada, I would say is that surgery has been the most impacted when we're talking about treatment delay. So that's the time from when a cancer is actually diagnosed to when the first treatment occurs. The impacts on systemic therapy or chemotherapy and radiation, I would say overall has been less, still there. But I think surgery has been hardest hit because it's a shared resource. The ORs are needed for cancer treatments, but also for many other forms of surgery.
Thank you very much for that answer. And the next question I'll direct to Dr. Zacharias. How long is the backlog of surgeries in Ontario overall, and how can we get through them?
Absolutely, this follows well on Dr. Cordeiro's Dr. Hanna's answer. We know that more than 1 million Ontarians are waiting for surgery at the end of 2021. Now, these are a combination of surgeries, but they include hip surgeries, knee surgeries, cataract, hernia surgeries, every single surgery that, when it's not happening, contributes to the dysfunction and even the mental well-being of a patient. And so we are advocating for a very practical solution. We call these integrated ambulatory care centers to catch up on the backlog. So these would be a series of standalone surgical centers integrated into the hospital setting so that there is no queue jumping and there's not extra money paid to jump ahead of the line to get your surgery done. But just taking these lesser complex, lesser emergent surgeries, equally important, out of the hospital setting to free up some of those hospital beds and ORs, and bringing them into a focused surgical center, such as these integrated ambulatory care centers. Ambulatory centers would help to catch up on the backlog. These have been studied. They provide lesser complications, increased patient satisfaction, as well as caregiver satisfaction. And so we look to have those here in Ontario as well.
Thank you very much. And Dr. Cordeiro, the next question is for you. Is there an age group particularly at risk, and what steps can they take to reduce risk?
Well, we know that the median age of diagnosis of breast cancer is around the age of 55. So certainly within the woman's 5th decade of life is when the highest risk statistically of her getting a breast cancer. But I think to echo Dr. Seeley's point, it is important to know that those less than 50 years of age in Ontario are not being screened. And so those patients definitely need to be cognizant. They need to talk to their primary care physician about whether doing mammography is a good option for them. And everybody needs to be aware of their breasts and to be an advocate for themselves and make sure if they see or feel something that they're not sure about and that they're questioning, that they bring it to the attention of their healthcare provider.
Thank you very much. And a question for Dr. Seeley, or if there's something you wanted to add to onto those points.
Can I just add a point there, Emily? It's really important to recognize that the peak incidence of breast cancer is age 55 for the majority of Ontarians. But when we look at the subset of women who are Asian or Black, their peak incidence of breast cancer is in around 45. So that is why it's so important to have a family physician, to know the need to have a heightened level of concern for those women, especially historically underserved. And to the point of how can you reduce risk? Very difficult. There are some modifiable risk factors that would include diet, alcohol, and smoking, but otherwise it's largely being female and being older than 40. For the most part, unless you're high risk. Thanks. Sorry I just wanted to expand on that a little bit. Thank you.
And Dr. Seeley, we had another question. You mentioned a risk factor being female. Are the stats that we've been talking about today, do those include men who have been diagnosed with breast cancer? You could talk to us a little bit about that.
So men account for about 1% of all the breast cancers that are diagnosed in Ontario, and they are not screened. They typically present with a lump. Unfortunately, for these men, they often delay their diagnosis, and so they're often at a more advanced stage 2, 3, or even 4. So when men need to be aware, they can get this diagnosis, and they need to go to their family physician as early as they possibly can if they feel any new lump.
Thank you very much. And Dr. Cordeiro, could you talk to us more about patients who are experiencing longer waits for surgeries? How are they coping?
Thank you. I'm humbled on a daily basis at my patients. I think the resiliency of the Ontario population is tremendous. Uniformly, with very few exceptions, people are very, very understanding of the challenges that we face at this point in time. Obviously, any delay or any extended wait is distressing for them. But honestly, I have been continually humbled by how well that patients are taking this and how well they are waiting. If patients are having a really, really hard time, then we encourage them to talk to the hospital, to talk to their provincial member of parliament about the challenges that are being faced, so that we can hopefully lead to some action at the provincial level.
Thank you very much. And a reminder to journalists that you can put questions in the chat. We are nearing the end of our Q&A portion. Dr. Seeley, another question for you. When should women start getting mammograms? Should Ontario start screening women at younger ages?
So our research showed that women who lived in provinces that screened women in their 40s, and that would include screening every year. The provinces like British Columbia, Alberta, Nova Scotia, Prince Edward Island, those women were more likely to have an early stage of diagnosis of breast cancer than in the provinces that include Ontario, who do not screen women in their 40s. There's a great discrepancy in the guidelines adopted in every province and territory. So the Canadian Society of Breast Imaging, the Canadian Association of Radiologists is aligned with the National Comprehensive Cancer Network guideline that says that all women age 40 should be screened every year if they choose to be screened. So we would really be recommending that women in Ontario be included in, allowed to self-refer for a mammogram.
Thank you very much. And we're going to hand it back over to Dr. Rose Zacharias, OMA President, who has some closing remarks for us today.
Thank you so much, Emily. And thank you so much for your attention and your questions to highlight the various specific aspects of this critical issue. I really appreciate your attendance today. We hope that the information shared, of course, shows the urgent need, and I can't stress that enough, but the urgent need to fix the cracks in our healthcare system that have been exposed by 3 years of living with the pandemic. There were some cracks before, but we call them chasms now, and this is how we're experiencing them inside the healthcare profession. When a patient is fighting cancer, we know that early detection and treatment saves lives. So we must reduce the backlog of services and fix the wait times. We also need to address the fact that too many Ontarians don't have a family doctor. So they aren't getting that preventative care that I was referring to earlier that they need, and they can't easily access the rest of the healthcare system. Ontario's doctors have solutions for many of the structural issues in the healthcare system. We call it our prescription for Ontario. It clearly outlines our pillars there, and we are committed to working with government to see our solutions implemented. And so I just want to briefly highlight 3 that you've heard referred to, but they are inside our prescription. We are calling for the licensing of more foreign trained physicians as well. We want to move ahead urgently with the creation of these integrated ambulatory centers for those less complicated outpatient surgeries and procedures to ease the burden that has been highlighted here on the hospital, and to reduce the wait times and get the women that we've been talking about today. Every number represents a woman and her story. Get them in for treatment. We want to create also more hospice beds and palliative care services to improve the patient experience, to support caregivers, and to reduce pressures on the emergency department. My clinical background is emergency medicine, 20 years in a community hospital working as an emergency room physician, and I never believed that there would be a day we would close emergency departments, but that is what we've experienced over the last several months, and it really highlights the extreme situation that we're in right now. So thank you for your attention, for bringing more attention to this topic today, and I want to thank all the panelists in the room, and I'll dismiss us now. So thank you for coming out. Bye-bye.